Now I'd like to introduce you Professor Flavio Kapczinski. He's a full professor at the Department of Psychiatry in the Federal University of Rio Grande do Sul. His main area of interest is bipolar disorders and neuroscience.
So, good morning, everybody. I'm gonna talk about some ideas from our group in Porto Alegre, south of Brazil, which are related to a new concept, which is called neuroprogression, and also to the concept of staging in psychiatric disorders. So, as you'll notice, some of the data is more related to basic science, but a lot of what I'm gonna talk about is potentially useful in the clinical practice. So to keep the Scandinavian mood after the last presentation, this slide is to call your attention to the fact that within the brain things are moving very fast and all the time. All the time you have new connections being created. You also have loss of existing connections. And so the brain is a very dynamic setting, and it's being shaped all the time, basically. And of course, as you got to know in the many talks of these conferences, there are critical periods in the infancy, adolescency, and maybe aging that those changes would be more pronounced. Some of those changes we think are disease-related, and then we call them neuroprogression. I'm gonna explain how we are thinking lately on this topic. To set the stage in the bipolar disorder, so of course you all know the disorder is being described since the classical Greek times, but the real good and even useful today description is done by Kraepelin, this being more than 100 years ago. And Kraepelin, was a sensitive or sensible researcher. He changed his mind a lot of times, so when you say Kraepelin says that, it's not that easy to interpret, because he said some different things in the beginning of his career from what he said at the end of his career. But essentially, when he talked about the manic depressive insanity, he wanted to emphasize most of the times that this was a phasic disorder, meaning that you had periods of well-being and euthymia, and those periods would be free of symptoms, and then patients would be suffering attacks of the disorder that would be either manic or depressive or mixed episodes, and then back to normal. So in short, that was let's say the classical concept by Kraepelin, right? Let's not get too much into details to avoid this is for the sake of the argument I'm gonna make. What's up? Okay. Oh, there's a delay between pressing and changing slides. Yeah. Back. I want to go back. Yes. One. Next. Okay. Back to the former one, please. Yeah. So Kreplin was telling us about this disorder that was occurring in acute phases and periods of well-being. The current literature does not confirm that. We know currently that people who had many episodes of bipolar disorder, not always, but a good proportion of them will have some cognitive impairments, some changes in their brain tissue, and some progression seems to be taking place in the course of the disorder. So this we call neuroprogression. Next one. This is important concept to our way to see this whole thing. We can measure in the acute phases of bipolar disorders several changes in the periphery related to inflammation, oxidative stress, changes in neurotrophins, and you can see there, I hope you can see this. Okay. Several indicators of toxicity or homeostatic malfunctioning related to oxidative stress, then inflammation and some neurotrophins show us that the control subjects are close in terms of those measurements to euthymic patients, so bipolar patients who are not in episodes. But then if they are within a full-blown episode of depression or mania, they have a lot of inflammation going on, they have a lot of changes, bodily change, let's say, to the point that those changes are comparable to patients who are having septicemia, right? So we are not talking about very minor things. It's measurable and in some patients present, and is very consistent. Okay, here we have the same picture, but we show this in a different way. For instance, the type or the magnitude of the toxicity presented by patients with septicemia is found in some patients with acute mania. And clearly, the pattern of depressive patients and manic patients is different from the euthymic patients, which is similar to the control population. Even having in the control population a subset which is different from any type of disorder, even euthymia. So this means that something is going on in episodes, some type of, let's call it provisionally, toxicity is taking place, and maybe this is one of the propellers of the neuroprogression, right? We don't know that, but it may well be so. Next. For instance, this is I'm bringing the very late findings from our laboratory, and you have peripheral cells from controls and bipolar patients. Those patients are in episode, acute episode, and those cells, and usually we study white cells, they are more prone to go into apoptosis, right? So it looks like there is some activation of probably pro-inflammatory pathways that mark the cells to death. Of course, you know that when a cell is dying, it's not like I'm dead. It's a long process. Usually, the apoptosis takes various steps, and it all initiates with inflammatory factors docking in the membrane of the cells and then initiating a long and complex cascade until this cell is really is not existent any longer. So, okay, next. We have, when this programmed cell death, like apoptosis, is taking place, it's highly regulated, is different from necrosis, so we should see this as a kind of organized way to die. But even then, when the apoptosis is taking place, a lot of factors are circulating, and the body is aware that something is going wrong. And one of the things that is circulating in situations of apoptosis are the dumps, factors that are liberated from the cellular compartment and the mitochondrial compartment and then are circulating in the body. Those dumps could be nuclear DNA, heat shock proteins, uric acid, mitochondrial DNA, cytochrome C, and many others. Many of those dumps have a receptor to them. So this means that when a set of cells is dying, those signals are being spread, and other cells, particularly from the immune system, are aware of that and they are reacting. Next. And then here we have, this is a paper from our student Laura Stertz, very bright biochemists from our laboratory, showing that in bipolar patients during acute episodes, we have this evidence for cellular death, right? Then you can see them in terms of the Young mania and Hamilton depression since the beginning of the follow-up to the week 16. And then you can see that the sum of these factors, like mitochondrial DNA and nuclear DNA, are very high when the patient is in an acute phase, and then it's going down when you get to the point of remission. So there is some indication of toxicity and cell death, which is going on in acute episodes and is resolving when patients get asymptomatic. Next. Could those factors be markers of clinical remission in bipolar? We don't know yet, but you can see the picture. All those dumps are going down, apart from uric acid kids is going a little bit up, but the general trend is going down. We don't know that yet, and we even don't know if having markers of acute phase may be a useful thing in the clinical setting, because if you know that the patient is depressed or manic, just examining the patient, why would you care to have these exams? But the possibility that some of those things would be altered before the episode would be very attractive clinically, because then we could predict the emergence of the episode. And even if some of those factors are present when the episode is resolved, is interesting as well, because it may show that there is some illness-related activity, or maybe some underpinning of the disorder is active there, even when the clinically observable episode is gone. So I think it has an interesting potential to the future. We know also that those peripheral cells have changes in their mitochondrial functioning, and this has been assessed in our group by Carolina Gubert. In other groups, it's been described as well. Next. And there is also indication that those changes are taking place not only in the peripheral compartment, which is the one we investigate the most, because we don't have until yet the possibility of investigating post-mortem brain. But people who are doing this analysis, they find parallel findings, which is changes in the mitochondrial complex, oxidative stress, and inflammation. All those signals are there. Next. Well, this is in the biological or the cellular side, but what is going on in terms of functioning? Then if we assess, this is another investigator from our group, Adriane Rosa. She was the one that developed FAST, which is one of the most used scales for assessing functioning in psychiatric patients. Well, and what we see is that bipolar patients of first episodes and multiple episodes have a different functioning, and this is clearly measurable. Patients who function, like controls in the first episode, they tend to have a much poorer functioning if they have multiple episodes. Would that be a linear fact? Everybody would have that? Of course not. Of course, when we deal with clinical populations, we all know we have those patients, and some of them, even having many episodes, they function much better than us, and they are very productive and, unimpaired. But some of them, unfortunately, they follow this pathway of losing functioning, losing relationships, and suffering this impairment in their working condition, which is a real challenge for us to treat. Next. Not only that, this is already a classical set of data. This is one type of way to show that, but it's been shown in different ways. Alan Swan, in his work, has shown that response to lithium, for instance, vary according to the number of episodes. So, in average, if you have until like 10 episodes, you would be a responder to lithium. After this point, the response to lithium falls, and usually within the clinical setting, those patients are under more complex treatments, such as lithium plus valproate plus some atypical, in the hope of restoring, the euthymia and perhaps functioning or normalizing sleep. Next. If those patients they have they are losing their function, their ability to function, they are losing their response to treatment, we may well think that there is a progression in their disorder. And if this is correct, we may think of a staging system. And the idea of staging psychiatric disorders is being debated all over. This was launched by what some people call the Australian school, and the champion of that was Pat McGorry. And then the idea was that you could detect early phases of the disorder, and patients who have gone through this pathway and are in a later stage. And so nowadays we are in the point that there are several systems of staging in bipolar. The one that we have put forward briefly is that some people are in ultra high risk. They have relatives who have bipolar disorder. They have symptoms, but they are not threshold bipolar patients according to the DSM, for instance. Stage 1 are the patients described by Kraepelin. Those are the guys that have the episodes. When they are not in an episode, they are functioning well. They go home and they have their families and they have their jobs and they live, normally. Stage 2 is when they have comorbidities, such as they are abusing alcohol, or they have axis 2 comorbidity, or they have axis 1 comorbidity like panic disorder or OCD. And then we have to treat the comorbidities and hopefully bring them back to stage 1. When they are in stage 3, they have a marked impairment in cognition and functioning. So those patients, typically they cannot work any longer, or when they work, just as a lawyer that I saw a couple of days ago, she's bipolar, had a lot of episodes. She cannot organize herself to the point of working as a lawyer, but she's got a friend who is a lawyer as well, and he's going to his practice, and she's organizing some attraction of new, potentially new clients, right? So she's doing a simpler task in order to be there somehow, and she is absent many times, but anyway, she's doing something. Again, she's doing something, but in a much lower level than we would expect to her previous accomplishments and her degree of education. So we call that stage 3. Stage 4 would be those patients who cannot take care of themselves anymore. They have to have the support of their families. Usually they are 50 years old or more, maybe 45 or more, typically in their 50s, and they would have to have help from family members or a day hospital to organize a very practical thing as paying their bills and dealing with money and keeping their house clean. Next. From our group, again, one image that is typical. This is a patient with few episodes, good responder to lithium. Patient is 53, right? And you can see, more or less normal brain shape. Here you have a 59 years old patient with multiple episodes, and you can see, this is very clear loss in tissue in the prefrontal area, ventricle enlargement. And this is the pattern that we find typically in the stage 4 patients. Many of you would say, well, this is more or less obvious, that those guys are taking so many medications, they are suffering so much, and, their brain, of course, is not, terribly well. But surprisingly enough, if you go through the best guidelines for treatment of bipolar patients, no mention is made to the fact that some of the patients have gone through this way of deterioration, loss of functioning, loss of brain tissue, and loss in their cognition. And more important, the way they respond to treatment is changed. So we cannot, in terms of the bipolar disorder, ignore the fact that the way the disorder progresses have to change our clinical practice. So when we talk about staging, we are not stigmatizing anybody. We are not saying, well, you are staging 4 and we cannot help you any longer. It's not the case. We are saying we are trying to do some more personalized care, and we are saying that the initial presentations are different from the late presentations, and in the late presentation maybe the focus is getting patients back to function, and is a kind of rescue, whereas the focus in the case of early presentations is everything to prevent episodes. Next. You can see here we have separated patients from our clinic in these stages according to the method that I've shown you. And then we assessed functioning using this fast scale. And you can see how nicely it goes from controls with good functioning, bipolar 1, stage 2, stage 3, and stage 4. So we are preparing this manuscript, and we are to the point that we want to call this way we stage bipolar as functional staging, right? We think functioning is the key thing to define those patients. Next. Rafael Massuda from our group is here, part of the Y-Mind, and he was doing some training on imaging. This is not a traditional thing in our group, but we thought that we needed to go more into that to, to be able to quantify those changes that we are seeing clinically. Next. 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 You ask Massuda what's the meaning of that, because he will be able to tell you. If you assess executive functioning, then you have, again, this is essentially functioning of the prefrontal cortex. This is the representation of the controls, right? They are doing this much of performance. This is bipolar stage 1, and this is bipolar stage 4. And here you can see that not everybody is there with a lot of difference, but it ranges in a very different way than the bipolar stage 1. So there's clearly something going on here. Is not the aging process that is taking place, is being controlled for. There's something related to the progression of the illness. Next. Again, from Massuda's study, Massuda and Clarissa. Clarissa is the one that is leading this effort. Clarissa Gama from our group. Here we have the controls, the bipolar stage 1, very similar to the controls in terms of sizing. Essentially, this is prefrontal cortex, and you see this much of difference going on in the total volume of prefrontal cortex in the stage 4. So we think this is pretty much unequivocal. Of course, this is not original description by our group, but what we are saying is that you can predict much of those changes in the brain if you use a staging system, a functioning staging system as we are describing. So maybe this is going to be a valuable tool for our clinical practice. Next. Well, then back to the biochemistry, and then we have inflammation-related factors such as this F-kappa BP5, which is increased in the late stages of bipolar, right? So we do have some changes in those markers that are not just state-related, as I mentioned to you initially, but maybe they are stage-related. Next. Well, here we have this takes into consideration being control in a bipolar patient. And then I have later on one in staging as well to show you. But to make a long story short, the lymphocytes of the bipolar patient don't respond to endoplasmic reticulum stress. Endoplasmic reticulum stress is a way that you stress the cell, inducing cell death. And by some reason, the cells of the bipolar patients are not responding. The simpler explanation to that is that those mechanisms have been recruited already. So those cells are already under stress, and if you give them further stress, they are not able to react anymore. Next. And then you have early bipolar and late bipolar, and this endoplasmic reticulum stress-induced cell death occurs more pronouncedly in bipolar late stage than in controls or bipolar early stage. So this toxicity I was talking about in the beginning of the talk seems to be more pronounced in these late stage phases. Next. But then you may ask, why bother with these peripheral changes? There is inflammation, but it is all there. It's in the blood. What does it count to the brain? But then, briefly, I would like to show this experiment to you. They have made an anastomosis of the blood of young rats with old rats. And in young rats, you had a lot of neurogenesis in the hippocampus, as you can see. When the blood of the old rat circulates in the young rat, you lose this neurogenesis. So what is circulating in your peripheral blood matters to the shape of your brain, as I've shown in the beginning of the presentation. Next. Next. And this is a very early finding from Gabriela Colpo. I decided, it is young minds, to put nice picture of the young people working in the laboratory. But if you incubate the serum of these acutely ill bipolar patients with neuronal cultures, you induce more cell death when you incubate with patients in acute phase than euthymic patients, right? So those inflammatory markers that are circulating, they make a difference and they kill the cells somehow. We don't know how this takes place. Next. This I'm gonna give you now the kind of, we are ending the time, but I will tell you more or less what we are thinking of all this currently. We think that inflammation is an important thing, going on in acute phases of bipolar, in late stages of bipolar. If inflammation is important, inflammatory cells are important, so white cells are important, and the inflammatory cells within the brain, the glial cells, would be key to this this whole story. Next. And then we are, doing this type of studies. Next. Next. This is just to show, how they look like, these astrocytes in brain tissue. Next. And then we are finding some interesting findings, not from our group, but from other groups showing evidence of activation of microglia and astrocytes in the prefrontal cortex of bipolar. It is just like, the inflammatory, cells of the brain are being activated. They are, involved with this inflammatory process that we can capture in the periphery. Would that inflammation that we measure in the periphery be leaking from the brain, or would the inflammation in the periphery leading into brain changes, or one thing doesn't have to do with the other? We don't know at this point. Next. But we do know that we have changes in glial cells and loss of glial cell density in the prefrontal cortex of bipolar patients. Next. Oligodendroglial density is changed as well in the bipolar population. Next. And the number of oligodendrocytes per neuron, so those oligodendrocytes will be kind of protecting the neuron, will be around there organizing the neuronal niche. We have a loss in these cells in the bipolar patients as compared to controls. Next. So Laura again made a very interesting, very clever hypothesis on how would that story fit. Maybe in a first episode you have some type of neuronal damage, and then you have to activate the microglia to repair those changes in the neuron. And then you have the pruning of the damaged bits, right? And you have a synaptic adaptation attempt, right? According to Laura and according to what we are working nowadays, we believe this is the basis of neuroprogression. Next. It would go like that, an attempt to restore the neuron. My time is gone. And then this is one possibility. Some of those inflammatory factors would leak from the brain to the periphery, and then this peripheral inflammation would in turn activate these microglial cells. Maybe a cycle is going on here. Maybe you guys from the young mind generation will be able to tell us in the future, what's going on in this complicated story. Next. But to summarize, we come to the idea of neuroprogression. What is neuroprogression? What we believe is neuroprogression. We believe neuroprogression is the pathological brain rewiring that occurs in bipolar disorder, but in many other areas of psychiatry. I would like to see some of you guys taking an interest in the field of addiction, which is the field that is more, related to neuroprogression than any other field, or in the field of trauma. Someone is normal, has a trauma, and then everything is changed. The hippocampus is shrinking, the prefrontal cortex is shrinking, and they are dying earlier than they should. So those are areas in which staging should be more seriously considered. I'm so much, into this idea of neuroprogression that we are kind of organizing a book by Oxford University Press on the topic. And initially I thought in doing neuroprogression in psychiatry, but of course you need to have a focus, and at the end of the day we are doing this for bipolar. But I would encourage you guys to look into these ideas. I think they are going to be relevant in our field. We may have biomarkers, and then what would be the pathways to neuroprogression? so far we think neuroinflammation is a good candidate. Oxidative stress, maybe as a result of inflammation. Mitochondrial and endoplasmic reticulum stress dysfunction, would that be related? I don't know. And neurotrophins, of course, this is downstream. Probably the problem is here, and then we see this lack of normal expression of some important proteins as a consequence of all this dysregulation. We may have a scenario or when we have biomarkers of neuroprogression. Most likely, this is not an intrinsically neuronal process. It's more likely to be a glial process. And if we have an advance in this field, we may be in a better position to have more individualized treatments in the field of psychiatry, which of course, and I'm sure you have discussed it a lot in these talks, in this Why Mind, is terribly heterogeneous population. It's difficult for us in psychiatry to say, well, this is degree X artery dysfunction, you should treat with heart surgery. For us, it's more complicated. Each patient have a story. They have a disorder, but the disorder is embedded in a developmental pathway, as it was shown. This is coming from the early years, and we have to keep all that in mind when we treat our patients. We clinicians, and I'm clinician in a good part from my activity, we do that intuitively. We look into the patient's story, we look into the family, and we try to fit the treatment to the needs of our patients. But I think collectively, as psychiatrists, we should be able to put in words what we are doing, what is this type of tailoring that we are doing to each patient to treat them better. And I think this idea of staging psychiatric disorders is an important step to, to have this intellectual insight incorporated in our clinical practice. So with that, I finish this talk. And again, I would like to thank you very much, you guys, for inviting me. If I believe in staging, I should believe in the young generation. Of course, your brains are better than mine. And maybe some of those problems I'm presenting here, you guys in your labs will be able to get some nice answers. So thank you very much.
Congratulations, Flavio. We all have been very proud of your work and a model. I was thinking, how can we use this model to apply to other psychiatric disorders? You mentioned that inflammation probably is not a specific. Inflammation is a mediator of mental phenotypes in our specialty. It's not specific of bipolar. Probably other disorders are mediated through the same process. And I wonder how would you reconcile your findings with what we have been learning from other non-communicable diseases like diabetes, like cardiovascular disease, like cancer. We see that these disorders are risk factor for mental disorders. Mental disorders are risk factor for these disorders. And I wonder if this late stage bipolar group, probably they also will have more diabetes, more cardiovascular disease, more cancer compared to earlier stage, I would guess. And also you mentioned this idea that you can understand inflammation from inside the brain, from the immune system inside the brain, the microglia, and the activation of this astrocyte and these cells. So we generated inflammation through the brain and not from a systemic perspective. So, so we talk about system biology and the idea of how you integrate this inflammation findings in the whole body functioning and what's consequence.
Yeah. So, of course, this is intellectual provocation, right? Is a very complicated thing to answer, but we can begin saying that you know, philosophically, as the biological mechanisms are highly you know, you have one function serving several purposes in nature, right? You don't have, you know, for each thing a different pathway. One pathway is dealing with many functions, and this is in all biologies, not only in pathology. So if in biological systems you have this type of conservation of mechanisms, or you use one thing for different purposes, this is the case of our genes, for instance. They are not, they are doing, you know, producing one protein, but this protein is serving many purposes. Pathology is conservated as well, right? If you think of what is the basis of atherosclerosis, you will find inflammation. If you think on what's the basis of type 2 diabetes, you find inflammation in the pancreatic cells. And it wouldn't be a surprise if you would find inflammation in the pathophysiology of chronic psychiatric disorders, because you know, of this situation. What comes first? For us, it's too early to tell. We really don't know. It may be just that you know, those patients who are doing, you know, who are not doing well in their lives, they have a lot of you know, bodily disorders, and their brain is aging faster, and that's what we are seeing. And I don't dispute that. Maybe this is the truth. But anyway, the brain is different. What I'm saying is that from the pragmatical, clinical perspective, it doesn't matter if the brain is different because of the diabetes or because of the changes induced directly by the disorder, but it's different, right? So when we think about a staging system, I'm thinking about a clinical staging system, looking into the reality and being able to say that the difference that we find in the clinical practice are there, and it's better to describe them than just to ignore. So that's the way I see, you know, those two questions. Yeah. Thank you for the question.
Okay, thank you very much, Professor Kapczinski.